Okay, so first thing, diabetes. What the heck is going on in diabetes? There's been, I think, an evolution of thought around the causes of diabetes and what is actually the sort of the crux of the physiological and metabolic abnormality and pathology. Explain to me, like, big picture, what is actually going on in insulin resistance and diabetes, and what is the crux of that metabolic abnormality?
Yeah, it's a great question. And it really is sort of the pinnacle of metabolic dysfunction. Uh, you know, all, all roads along this metabolic dysfunction pathway lead to type 2 diabetes. And I classify this as sort of the type 2 diabetes spectrum. And on one side, on one end, you've got things like insulin resistance and metabolic syndrome, which is slightly elevated blood sugar, high blood pressure, overweight, but not necessarily obese, dyslipidemia, so high cholesterol, high triglyceride levels. And then you start progressing down that pathway, and it can manifest in different ways. For example, PCOS, which is something that you don't necessarily directly associate with diabetes, I would put along that spectrum because it's part of that insulin resistance continuum. There's pre-diabetes, which is just sort of early diabetes, type 2 diabetes. And then there's other conditions along that spectrum that I would put like Alzheimer's disease and other forms of dementia, which have been tied to insulin resistance. So it's a huge, huge thing. And some estimates say 7 to 8 out of 10 Americans have some sort of insulin resistance, hyperinsulinemia. May not have prediabetes yet or type 2 diabetes, but are on their way. And
which is an interesting statistics when you consider that about that exact same percentage of the population is the percentage of people that are overweight or obese.
Exactly. And there is a large overlap, but not 100% overlap. So I'll talk about what type 2 diabetes isn't first. And it's not obesity. Obesity is a major comorbidity, as we say. So it goes with it often, something like 80% of the time. But there are people who are obese who don't have high blood sugar or prediabetes or type 2 diabetes. And there are many people with type 2 diabetes who are normal weight or perhaps slightly overweight, and some who are underweight as well. So it's not the exact same as obesity. Again, they do oftentimes they're sort of cousins because they sort of have a common cause in most people, but and they can feed off of each other, so to speak.
Mm-hmm. Now, so you said many people. I just want to get a sense of what the percentages look like. And my understanding is, and you correct me if I'm wrong, but my understanding is those two populations that you just mentioned, the insulin resistant or diabetic people who are not overweight necessarily, and the overweight people who are not insulin resistant or diabetic are more the exception than the rule. But
yeah, so
talk like specific.
Let's say it's 20. Let's say it's 20%.
Okay.
There's 100 million people in the U.S. right now with prediabetes or type 2 diabetes. So 20 million. That's just a rough estimate. Of course, I don't know that number specifically, but if we use some of the stats, 20% of 100 million is 20 million. So that's where the many people comes from.
Okay, that's 20 million between those two groups.
Between those two groups. And I tend to see more of those people, I think, because of the people who, try to search out for answers. They've already gone to their doctor. Their doctor doesn't understand why they have diabetes when they're normal weight. So they're looking for another opinion. So I tend to see probably 30% of my patients, clients fit into that category, but that is a little skewed high.
Interesting.
It's also not hyperglycemia. So oftentimes people think that diabetes and hyperglycemia are the same thing. And in fact, medically, most of the treatments for type 2 diabetes are in fact really treatments for hyperglycemia. Hyperglycemia just means high blood sugar. But of course, there's many other things that can cause high blood sugar. You can go on a course of prednisone, for example, without having diabetes and end up with high blood sugar and never develop diabetes. So there are other things that cause hyperglycemia other than diabetes. So we can't confuse diabetes and high blood sugar and think they're the same thing. Because again, the problem there is if we believe that, then our treatment is all around lowering blood sugar, and we forget about the underlying root cause of why the blood sugar is high in the first place, and what is underneath that, and all the other sort of spider web myriad effects and consequences that come from the underlying cause.
Yeah, it does. So that's a perfect segue into what those root causes are. So what's the sort of big picture paradigm of the key, I don't know if you conceptualize it as the key 2 causes or the key 8 causes, but how would you paint that picture of what are the causes of insulin resistance and diabetes?
Yeah, no, and I'm glad you said it that way, because so we have type 2 diabetes and prediabetes and metabolic syndrome and PCOS and Alzheimer's disease in this continuum. Most of the time, again, nothing's 100%, but most of the time underneath those is both insulin resistance and hyperinsulinemia. So we have resistance to the hormone insulin, which helps us to regulate our blood sugar and other fuel. It's basically a storage hormone that helps us sack away excess energy for later use. And our bodies become resistant to that. We'll talk about some of the reasons why that happens in a minute, but we become resistant to that hormone. And then the next step, which is really what does a lot of the damage, is our pancreas then in turn starts overproducing insulin. So insulin resistance in and of itself is a problem, but the bigger problem is the hyperinsulinemia that comes from the insulin resistance. So the pancreas starts overproducing insulin, and now we've got all this extra insulin on board, which causes us to store fat in strange places. We store fat in our liver, in around the organs, intra-organ fat, visceral fat. We store it in the muscles. We store it just about everywhere because insulin just sort of opens that gate. Now, it's not going to do that. It's not as simple as I just made it seem. There's a lot more to it than that. But in the presence of extra energy, we'll say that if you're overeating, which most Americans do, unfortunately, especially with diabetes. So if you're overeating fat or overeating carbs or overeating both, which is usually the case, and you've got high insulin levels, the body's going to force all that extra energy into fat storage, and in places where you don't want fat storage oftentimes, because the subcutaneous fat, that fat around the belly or the legs and buttocks and so forth, will reach at some point a threshold, and then we start storing that fat other places.
Yeah.
So it's the insulin resistance and the hyperinsulinemia, which then drives all kinds of problems. We said fat storage. Insulin acts on the kidneys to cause us to retain fluid and electrolytes. So our blood volume increases and our blood pressure increases, and we retain fluid. So a lot of people with hyperinsulinemia get swollen ankles, for example, and a puffy face and puffy hands, and they're very inflamed. Another thing that it does is degrades the endothelium of the blood vessels. So we get endothelial dysfunction, which can lead to oxidative stress and plaquing and atherosclerosis and cardiovascular disease and stroke. So all of those things independently of what the blood sugar is doing. So you can have completely normal blood sugar and insulin resistance and elevated insulin, and it can still cause all these problems, including, as I mentioned earlier, Alzheimer's disease. A lot of the Alzheimer's disease research has found that people with insulin resistance, even with normal blood sugar, are at a much higher risk of Alzheimer's disease. So we have to separate the high blood sugar from the high insulin. Now, I'm not saying that high blood sugar is not an issue. It is. Once that blood sugar starts to rise, which is a little later down the line in the type 2 diabetes chain, so to speak, now it's compounded and we get all kinds of problems happening, which again we can get into if a little later if we want. But I want to answer your question, and I wanted to set that stage because to me that insulin resistance and high insulin is sort of the cause of the diabetes, of the pre-diabetes, of obesity many times, of PCOS, of Alzheimer's disease many times. But there are causes of that as well. So we have to go deeper and look at the cause of the cause.
Yes, exactly. That's a perfect way of phrasing it. I'm glad you said that because I almost wanted to interrupt and add that earlier. But I just want to point out for a lot of people listening that a lot of the way people conceptualize causes depends on one's paradigm that they bring to the table. So if I would say the conventional medical paradigm is sort of like they stop basically where you just left off. So they've painted the picture of hyperglycemia, hyperinsulinemia, some of these other biochemical metabolic abnormalities that you've spoken about here. And then they're conceptualizing those things as quote unquote the cause of diabetes. And therefore those are the things that we need to fix. And of course, since our philosophy and our paradigm revolves around sort of interruption of aberrant biochemical processes with pharmaceuticals, we need to develop a pharmaceutical or two to interrupt those quote unquote causes. Your paradigm, which I think is, in case it's not clear to people listening, I think is a much more intelligent and sophisticated paradigm, is to not stop there, but then to connect all of those biochemical abnormalities with the environment and lifestyle and nutrition habits at the true root cause level. And I think, we have to be careful with our use of language here, because I would say the only thing that we should be referring to as causes are really the things at the most root cause level possible.
Right. I totally agree. And the only reason I went through all that is because what a lot of these things cause is not the high blood sugar. They do in the long run, but they're directly associated with insulin resistance and high insulin levels. So we have to look at that as sort of that important go-between. But you're absolutely right. Most physicians, researchers go sort of one level deep, and pharmaceutical targets will sometimes address that one level deep. There are, for example, a few diabetes drugs that address insulin resistance. Really only one that's used now, which is called metformin. But most of the diabetes drugs really only address the sign or the symptom, which is the high blood sugar. So certainly none of them really are addressing these root causes that we're going to get into. So so there's many, and probably 10 or 12. Certainly we can look at dietary factors. I think eating a sort of an unnatural diet, I'll just put it that way, a diet that's heavy in processed and refined foods, and whether that's processed refined grain products or refined sugars or refined processed industrial seed oils, what we call vegetable oils, which are pro-inflammatory and highly toxic. Whether we want to look at, just packaged foods and fake fats and so forth, all of this stuff, not to mention the chemicals that are added to these foods, can drive inflammation. And you're gonna hear me mention that word several times over the next few minutes, but inflammation is really one of the primary drivers of insulin resistance. So we see there's been several studies, for example, that show how a chronic systemic inflammatory process actually gums up the insulin receptors and blocks insulin from being able to interact with its receptor, almost like if you think of the key in the lock analogy. It's like the key can't open the lock. And inflammation does that. Now, here's another one. We could go another level deep on all the things that cause inflammation, and
Right.
I think we need to do that. But that's another sort of, factor that tends to drive this whole process. These foods, though, these fake foods, unnatural foods, so to speak, are one of the primary drivers of that inflammatory process. We don't move like we used to, and I think, even people who do exercise, a lot of times they'll go to a 1-hour exercise class, and the rest of the day they're sitting, so they're sleeping all night. They wake up, they sit in the car, they sit in the office, they come home, maybe they get an hour of exercise, and then they sit on the couch, and then they go back to bed. So it's like the body's not meant to do that. We're not designed that way. So unfortunately, that's a factor that is an important one, because there's so many important things that exercise does for the blood sugar regulation system, including driving glucose into the muscles to be burned for fuel, emptying our glycogen stores, which is the stored sugar in the liver and muscles that we then need to refill. We actually don't even need insulin when we're contracting muscles to soak up glucose into the muscle cells. Just the muscle contraction alone will allow glucose to get into the muscles, into the mitochondria and the muscles to be burned for fuel. So exercise is hugely important, not to mention cardiovascular health and circulation and lean muscle mass, which increases metabolic rate and so forth. So that's a big one.
Just what to add to that, I have seen at least one, if not two, maybe three studies. This is a few years back when I was digging into the literature on this, so I'm a little rusty, but at least one talking about measurable increases in insulin resistance from just like 2 hours of sitting, if I remember correctly.
Yeah, for sure. And not only that, it's a good segue, because another one that shocked me, I mean, I understand it's not shocking, but it's shocking of how impactful it can be. And that was a study which showed 1 night of poor sleep did the same thing, basically decreased insulin sensitivity and increased blood insulin levels. I think it was by 20 to 40%, somewhere in that range. It was a huge number.
Yeah.
And, these things can have a huge impact. So yeah, absolutely. Exercise, poor sleep, which I just mentioned, has a major impact. And sleep can decrease our insulin sensitivity, leading to insulin resistance. It can change our microbiome. Then there's other more psychological factors, like when we're fatigued, we tend to not eat as well, and we tend to exercise less. And our behaviors aren't as maybe ideal as we would want them to be, or they might be if we're well rested. There's gut dysbiosis, which is a huge issue. There's obesogenic guts and diabetes-inducing guts, where they've actually been able to replace the microorganisms, the microbiome of thin people and make them fat, and fat people and make them thin. With the change in microbiome. So or at least mice. I'm not sure. I think they did repeat it in people too. So it's
there's been some mixed data in humans.
There's been mixed data. Yeah, it's not. This isn't clear science.
But but
it's interesting.
There's definitely like enough research to show that the microbiome matters into whether it can be obesogenic and diabetogenic. But to your point, I think like some of the data is like, well, no, it didn't fully make someone obese just through the microbiome, which is like, of course, like, did we really think that it was just the bugs in the gut that was the entire cause of obesity? Like, that's a lot to ask to replicate studies like that.
Yeah, for sure. And, a lot of these things lead to changes in dietary patterns. So, when you have different gut bugs, you might crave different foods and eat differently when you don't sleep as well. Same thing when you don't exercise. Same thing. So a lot of these sort of what I'm calling underlying root causes oftentimes change your dietary patterns too, which is obviously a big one. And I'll mention one more. I mean, there's hormone imbalance, there's chronic infections, which can drive stress. There's adrenal dysfunction, all kinds of things that can affect our blood sugar. But another big one is mitochondrial dysfunction. There's been several studies on the connection between mitochondria and blood sugar and diabetes. So we know that ATP, for example, is necessary to release insulin from the beta cells of the pancreas. And ATP is actually the signal that tells the beta cells to release insulin when there's a glucose level rise in the blood. So when we don't have adequate supply of ATP, we don't get proper insulin signaling. And it's also mitochondrial dysfunction has been associated with insulin resistance again. So there's a lot of different connections here. And, this is one of the reasons why I get sort of frustrated when I hear people talking about diabetes in such simple terms like, oh, if you would just, stop eating sugar and start exercising, diabetes would go away. Certainly in some people that's the case, but oftentimes there are other underlying factors that we have to look at.
I guess it's important to emphasize that there's two types of diabetes, right? There's type 1 and type 2. Type 1 diabetes is an autoimmune condition where your immune cells attack and destroy your pancreatic beta cells that produce insulin. So all of the kind of the pathology and everything we're going to be talking about is focused on type 2 diabetes. Type 1 diabetes and type 2 diabetes can't be compared, honestly. The causes are just wildly different for the most part. There's a little overlap. But if diabetes is, based on your blood glucose levels, if you don't make insulin, your blood glucose rises. And that's type 1 diabetes. There's no insulin resistance. Someone could have perfect metabolic health and they would have diabetes because their pancreas is literally destroyed by their immune system, right? So again, there's that physical structure breakdown is now causing all of these biochemical things that we like to measure. But for most people, for 90% of diabetes cases, it's type 2 diabetes. And this is the apex of metabolic dysfunction. Like it's the tip of the mountain or the peak of the mountain that you would reach if you let metabolic dysfunction just continue without intervening to stop it.
Alex, let me have you go one more piece of context. So you mentioned that sort of the proportions of type 1 versus type 2 diabetes in terms of the overall pool of total numbers of cases of diabetes. But what about the context of, as far as the proportion of people with diabetes that relates to the total pool of the chronic disease burden more broadly, and all these other diseases like heart disease and cancer, and chronic kidney disease and dementia and Alzheimer's and so many others? Like, to what degree is type 1 diabetes contributing to that versus type 2 diabetes?
Oh man, I would say type 1 diabetes isn't even kind of on the radar with that.
Yeah,
type 1 diabetes
to understand.
Yeah,
like when we're talking about chronic disease burden more broadly, we're talking about type 2 diabetes.
Yeah, type 1 diabetes brings with it a host of problems, right? Like it'll literally kill you if you don't manage it with insulin. And that in that case, like that's a necessity to keep you alive. But as long as you keep it managed, the rest of your metabolic health, as long as that's in good shape, you're at no increased risk of disease. I have several friends that have had type 1 diabetes since childhood, and they're, some of the healthiest people I know because they take care of themselves. They maintain strong physical structures in their bodies. Now, and sorry, amusingly, and they all inject insulin out of necessity, but they aren't fat. Okay. So just had to point that out for the insulin equals fat gain people. But anyway, yeah, type 2 diabetes is, a leading cause of cancer, cardiovascular disease, and neurodegeneration. Because once you start having a breakdown of your metabolic health, that affects literally every organ system in your body, because now every organ system in your body, your blood vessels, your brain, your muscle tissue, your fat tissue, they aren't getting the energy that they need, or they aren't able to use that energy properly, while simultaneously being exposed to more energy than they can safely deal with. So it's like, man, imagine that, this might be a bad example, but let's say you had a car and you cut off half of the gas tank. So now you have half the room for gas, but then at the same time, you're letting gas just overflow the car. It's two related but separate issues. You can't use as much energy, which your cells need to function properly. And you're getting so much energy tried to be jammed in them that it's spilling over and damaging other components. This doesn't just happen overnight. And I want to emphasize this because I think you mentioned earlier that, 9 out of 10 people are considered to be metabolically unhealthy in the US.
I didn't mention that, but it's a good thing to mention. There was a study that the one that showed 88% of US adults are in poor metabolic health. And then I saw actually a recent one as we were writing this recent chapter for the book. There was another study a few years later that I think measured it in a slightly different way, and they found like 94%, an even higher number.
Yeah. And in those studies, what they're doing is they're taking physical measurements. So they're looking at people's obesity and that type of thing. And then they're combining it with markers of metabolic dysfunction, the biochemical markers that we like to measure because it's easy. And they say 9 out of 10 people aren't healthy. Now, diagnosed diabetes in the US is at about 12% of the population. There's another, 15 to 20% estimated to be undiagnosed because these people just don't go to the doctor. And then everyone else in that difference, so let's say that's what, 60, so like 60% of the population is in between. They aren't healthy, but they're not yet at diabetes. You could say, they have pre-diabetes. You could say they have metabolic syndrome, whatever. The point is,
I think it's important to understand. I think a lot of people don't grasp the concept that this is really a spectrum that we're talking about. Like, people, I think, have been taught to think of diabetes or even pre-diabetes, quote unquote, as like well-defined conditions that sort of you either have it or you don't. And once you have it, then you have this disease that needs to be treated in XYZ way. And I personally think, and I hope you'll explain, I'm going to ask you to explain this, the idea of insulin resistance and sensitivity as a spectrum. And that where we define specific cutoffs to say this XYZ is a disease state is really, to a large extent, kind of arbitrary. But a better way to understand this is a spectrum of optimal insulin sensitivity versus high levels of insulin resistance.
Yeah. So I think a little later, we're going to get into the structural breakdowns that cause metabolic dysfunction and diabetes. So I'm not going to go into that at this time, but what I am going to say is that fundamentally, what's causing type 2 diabetes to occur, which is the elevated blood glucose, is that there are problems with insulin receptors on cells where they become less responsive. And it's a spectrum, right? You can have, maybe they're 90% responsive compared to completely healthy. Maybe they're 80, 50, 30, and it just keeps getting worse and worse. And when insulin isn't able to bind to these receptors effectively and transmit the signal telling the cell to take up glucose from the bloodstream, then your blood glucose starts to rise or stay elevated after eating. Now, these receptors exist on virtually every cell in the body, and depending on where insulin is binding will determine what the effects are. So in the case of diabetes, when insulin's binding to muscle tissue or fat tissue, it's telling those cells to take up the glucose and either use it for energy or store it for later. And that storage can be in the form of glycogen in muscle or as fat tissue in your fat tissue. On somewhere like the liver, insulin's job is to actually not just tell the liver to take up glucose, but for the liver to stop creating glucose from other precursors like amino acids. And the primary reason why someone's fasting blood glucose elevates when they have prediabetes or type 2 diabetes is because of the liver. The liver is not receiving insulin signal to shut off its glucose making abilities. And so it, even when you're not eating, it continuously pumps out glucose into your blood that it makes from things like amino acids. And, doctors will see this and they'll say, oh, your fasting glucose is high. This is how we're going to diagnose you with either prediabetes or type 2 diabetes. Now, do they ever tell you, why that's happening at a fundamental level? No, they just tell you your blood glucose is high. And I don't know, maybe you should lose weight or you should go on a low carb diet or whatever, because your body isn't handling carbohydrates and glucose in your body properly. But fundamentally, it's the biochemistry is a symptom of the actual structural defects that are occurring in the body that are leading this to happen.
Okay, so let's before we get into that, what you're just alluding to there, let's go into the conventional, sort of the standard conventional ways that most people within conventional medical circles, and I would say within natural health and functional medicine circles, for the most part, tend to understand the physiology of insulin resistance and the way that they think about causation and treatment. So can you kind of explain how they tend to conceptualize this? Because I want to, and I want you to do it in a charitable and a generous way. I don't want you to misrepresent, I want you to be generous to their perspective, present it as fairly as possible. And then after we do that, then I want to contrast it with kind of the new perspective, the new paradigm that you want to present on insulin resistance.
Yeah. So I'll do kind of the conventional, and then I'll do what I would consider maybe the more alternative way of looking at it.
Great.
And both ways actually, address it pretty decently. We think that they're missing some important parts, but I mean, ultimately, they're keeping people alive. And what they do, conventional, let's say you go to the doctor, your blood glucose is elevated. The doctor is probably the first line of treatment from a conventional medical standpoint is to put you on metformin. Because what metformin does is they say, hey, your blood glucose is elevated. We're doctors, and so we know that diabetes comes from insulin resistance, right? They definitely know that. They know kind of how it's caused. And they say, okay, insulin resistance, so low insulin sensitivity, let's give you metformin, which is going to increase your insulin sensitivity and help your body naturally put blood glucose back where it's supposed to go in your muscle and fat tissue instead of having it hang out in your blood. And it works.
Problem solved, diabetes cured, right?
Well, maybe, if that doesn't work, right? Because for a lot of people, metformin doesn't get their blood glucose under control. Maybe it helps a little, but for a lot of people, they might not even have diabetes anymore, but they're still pre-diabetic. It's not that they're healthy. It's just they're less unhealthy. Mm-hmm. And, if the problem persists, or even if it gets worse, despite being on something like metformin, first they'll increase the dose. And once they reach the kind of max dose of metformin, they'll be like, you need to go on insulin. And then they're just going to have you start injecting more insulin. Because if you inject more insulin, well, now you're going to logically have more insulin signaling at the receptors, and you're going to kind of force blood glucose away into various tissues.
I might be jumping ahead here, but let's say that, let's use insulin. Let's leave metformin out of the picture for a minute. Let's say you just to talk about insulin in the way you just described. Let's say that you used insulin and you used it effectively to, meaning injecting extra insulin beyond what your body's producing. You used it effectively to keep your blood glucose in a relatively normal range to prevent it from being elevated. Does that mean that you don't have insulin resistance or diabetes anymore?
It doesn't have any effect on whether you have insulin resistance or not.
Right.
But from a diagnostic standpoint, you could not meet the diagnostic criteria for diabetes technically.
Well, that's a different discussion. I don't think, I certainly don't care about that. I care whether there's an actual problem or not our degree of the ability to measure the extent of the problem based on our diagnostic criteria.
Yeah. So here's the thing too. There's reasons why your insulin receptors become desensitized to insulin. And one of the reasons in kind of a positive feedback loop is that the more insulin you have circling around, the more the receptors become desensitized to it as a protective mechanism, because your cells aren't stupid. I think cells aren't just these little robots that just sit there and work in a very fixed manner. They're dynamic. They're constantly looking at what's going on around and within them and then adapting to that. And so when a cell has a problem and it says, hey, we have a problem and this is causing our insulin receptors to not reach the surface because we don't want that to happen, then you're going to inject insulin and kind of force more energy into that cell, which is going to just aggravate that problem. And that cell is going to withdraw even more insulin receptors from its surface. And you're going to have to continually inject more and more insulin to get the same effect. And in a sense, you're actually going to worsen the original problem, even though the symptoms of the disease seem like they're in control.
I want to make the distinction that I think what you're presenting now, this idea of, and you're alluding to the idea that there is an intelligence behind insulin resistance, that it's not purely the body's being dumb and this is a pathology, this is a disease, a problem of the body because the dumb body can't figure out how to control blood glucose. What you're saying, which is, I think, introducing a novel perspective that is not typically seen by most people within conventional medicine, and maybe, I don't know to what extent this is now common among natural health and functional medicine people, but I think in general, in conventional medicine, they see this as a pathology, not as the body intelligently making the cells more insulin resistant to protect themselves. Would you agree with that?
Yeah.
Okay. So with all due respect, I think you're jumping a little bit ahead in introducing some of the more novel perspectives. I want you to come back to the conventional medical and more typical sort of functional medical ways of viewing the physiology and the mechanisms of insulin resistance.
So conventional will say your blood glucose is elevated. Let's try and increase your insulin sensitivity using drugs. And if that doesn't work, we're just going to try and overpower your body by using hormones. And those hormones are just going to force your body to do things maybe it doesn't want to. Now, in this situation, the underlying causes are never being addressed. They're just being managed because they're focused on the biochemistry.
Let's circle back just to this. Just can you crystallize this idea of how most people view insulin resistance, and then we'll move on to the new paradigm.
Yeah, people say, hey, you're insulin resistant, you have high blood glucose, let's increase your insulin sensitivity or do other things that lower your blood glucose. We're not going to make any structural changes. What we're going to do is either give you a drug that increases insulin receptor expression, or, you know, we're going to change your diet to where, hey, if you're not eating carbs, then your blood glucose is normal. That's great. And those are the I would say the two most common kind of paradigms.
It tends to be a way of conceptualizing insulin resistance that sees it as a biochemistry problem.
Exactly.
With a biochemistry or pharmaceutical solution or chemical solution if it's a natural chemical.
Yeah.
Okay.
And even the dietary change can be thought of as a biochemical change because their focus is on blood glucose, right? It's on that biochemical marker. And by manipulating the diet, they're specifically trying to manipulate your blood glucose levels.
Mm-hmm. Okay. So with that said, and I know you've actually already alluded to the new paradigm a number of times, but let me have you introduce this new way of thinking about the root cause of insulin resistance.
So your cells are not structurally robust, and because structure dictates function, their function is no longer advantageous to your health. The more that you dig, the more that you realize that the cause of diabetes is fundamentally cellular dysfunction. And that can be brought on by several ways that we'll talk about, but that's ultimately the crossroads, is cellular dysfunction, which is causing these cells to be insulin resistant, which is then driving these biochemical changes in your body because the dysfunctional cells are not acting in the way that they should.
I want people to get this idea of structure dictating function, because I think we are all so trained in this culture, in Western culture, certainly in the US, to think of health in biochemical terms, to think of our health as a result of whatever is the list of items that show up on our blood test results at the doctor. Health, we think of health as we are a product of the chemicals, the levels of these chemicals and different compounds floating around in our bloodstream. And this idea of structure is a different way of conceptualizing health. Like, imagine imagine a bicycle, right? And imagine having a trapezoid shaped wheel on your bicycle. How well is that bike going to work compared to if it's a circular wheel? The structure of that wheel, the physical structure at the macro level, not biochemicals, not micro level biochemicals, but the physical macro level structure of what's happening in that bike profoundly impacts how well it functions. We are so good at understanding something like that, you know, with a bicycle. And I would argue we are so bad about applying the same logic and the same common sense to us, to ourselves as humans, when it comes to understanding our own health, to understanding the link between physical structure of our bodies and our physical function, our function, and ultimately our health and disease outcomes. So go in more detail about this, what you mean by structure, what is under the banner, the umbrella of this idea of the physical structure of our body, and then segue into how that is affecting the function of systems that relate to insulin resistance and metabolic health.
Yeah, so a really easy example of this to think about further, just to emphasize the structure component, is I'm going to give two examples here. First, with your muscle tissue, because I think this is really easy for people to visualize. What happens if you have very small, weak, frail muscles, right? Their physical structure of your muscle is not very good, and the outcome of that is you're weak, you're at an increased risk of falls, you're at an increased risk of injury from those falls, like, a hip fracture or many other things that are the leading causes of death and disability among elderly adults, because they are who this physical breakdown of their muscle tissue, they're who are primarily affected by it, right? Just as kind of a meta example of that, you solve that by doing resistance training, right? And eating food to support the growth of new muscle tissue. It's literally, hey, our muscles are weak. We're not going to, go look at your biochemistry and be like, oh, well, let's see how much creatinine are they responding? What's your blood urea like? It's like, no, none of that is relevant. The issue is a weak muscle. Let's build the physical structure. Let's make it stronger. And guess what a side effect of this is? Your muscle tissues are responsible for 80% of glucose disposal after eating. So
Alex, hold on one second before you go there. I want to add one thing to this point.
Yeah.
Of muscles. We can visually look at someone, and based on how they appear to us, like using our eyes, observing the macro level physical structure of their body, we can very easily and probably pretty darn accurately guess their physical function of their strength level of those muscles based on looking at the physical structure of them. And so if somebody's got big, strong looking muscles, we go, oh, that person's probably really strong, right? If they're physically very frail and they have very skinny, flaccid muscles, you're going to look at them and think, no, that person's probably not very strong, right? This is very obvious. This is very, very common sense. Importantly, I want people to understand if you went and did blood tests of those two individuals, the one who visually you said that's a strong person and visually said that's a person who's pretty weak and frail. If you did blood tests and what you looked at was a 10-page report of hundreds of different biomarkers in each of those people, but you didn't get to see them visually, you didn't get to actually look at their physical structure. All you had was what most people would think of as a much more cutting edge, much more scientifically sophisticated thing, which is this 10-page report of hundreds of things going on in their biochemistry. There is no analysis that you could do of all of that biochemistry, Mark, no matter how sophisticated. You could add microbiome tests, gene tests, you could add all the tests you want. You still will not be able to, by any of that data, have come anywhere close to as accurately predicting how strong or weak a person's physical muscles are as you would have by just a 5-second observation or a 1-second observation of a person's physical structure. So I want people to get like just how predictive simple observations of macro level physical structure are, and that this is not only not less scientific or less sophisticated or cutting edge than a biochemistry analysis would be. In many cases, it is actually far more accurate of a predictor of a person's physiological function than any analysis and any comprehensiveness of biochemistry tests.
Yeah. And I want to add to that too. Biochemistry is just a snapshot in time. And so what gets overlooked is the future risk of something happening. So in your example, the two people could metabolically be equal at that point in time. 1 year from then, the person who is very weak with low muscle tissue is much more likely to have developed metabolic problems from that low muscle tissue, because a breakdown in physical structure has a cascading effect. And the more time you spent, on that road, the worse it gets.
Yeah.
So Yeah, so you can't just look at one snapshot in time and think it's going to stay that way. That's the problem. People think it's static, and it's not. Remember, your body is always adapting to what it has to work with.